In this video, we'll talk about how to approach a case of palpitations in the long clinical consultation of the MRCP PACES exam. I've covered other cases such as dysphagia, vision loss, back pain, and seizures, also diarrhea. If you want to check those out, they are available in the LCC playlist on the channel. Okay, so let's begin. Palpitations can present in the exam in the form of racing or pacing of heart, awareness of heartbeat, missed beats, anything. So, before going into the details of the history, let's talk about how to prepare in those 5 minutes given outside. So, you would have to read the scenario twice carefully, and you'll be given a piece of paper and pencil, and you're allowed to take it inside so you can make some notes on it. At the top left corner, write down the patient's name and age in case you forget about it. Write down the setting. This means whether you're in the emergency ward, you're in the medical ward, or if you're in the OPD. This is important not only because of how you're introducing yourself to the patient in the beginning, but also how you approach the case. So, let's suppose you're in the emergency setting, you would have to address the patient's concern and give the viva to the examiners, thinking that you're in an emergency setting. So, it's important, but be mindful that even if the patient is presenting in the OPD, it can still be a medical emergency. So keep your mind open about the possibilities. The next thing is write down the presenting complaint and the duration. The duration might not be given or it can be given, so it can give you an idea whether it's an acute condition or a chronic one, or maybe a worsening of a chronic condition. At the top right corner, write down driving, job, and impact. These are important in any case, obviously, but driving in this case would be important if the patient had palpitations because of a cardiac cause and he had accompanying syncope as well. So, in that case, you would have to tell the patient to inform the DVLA and stop driving. The job and impact is important in all LCCs, but write it down in case you forget about it. Although if you're well practiced with the history taking format, it's hard to miss. Family history again is to be asked in every case of LCC, but here it's important because it can give you an idea about the underlying differential. For cases such as hypertrophic obstructive cardiomyopathy or long QT syndrome, those are familial, so it can give you an idea about the underlying differential. At the bottom right corner, you'll write down the things that you'd like to examine. So, in every case of palpitations, you have to check or at least offer the cardiovascular examination, but the order of examination would depend upon whether it's an endocrine cause, maybe it's a cardiac cause. So, depending upon the differential you have in mind, examine the relevant system first. Always check the vitals, offer the pulse, check the pulse yourself, obviously, offer the blood pressure and the postural drop, and then either check the relevant examination, the system first. For example, if it's an endocrine cause, you can check the thyroid first and then offer a cardiovascular examination. Otherwise, if the main cause seems to be cardiac, check the cardiovascular system first. Now, because this symptom is pretty vague and it's hard to form a differential in mind while you're outside, you can just write down the systems that you need to think about or rule out in your history. So, cardiac obviously would be number one, endocrine causes such as thyroid, metabolic causes, electrolyte imbalances, and then drugs or substances. That would mean medications, illicit drugs, even alcohol, caffeine, and tea. Okay, so starting the history, of course, after the introduction and the initial scheme, you would then ask the patient about the palpitations specifically. So, the number one thing would be to establish the character. You need to ask them about to describe the palpitations or the awareness of heartbeat or racing or pacing of the heart. Tell them, can you describe them for me or can you tap it out for me? That means you're establishing whether it's regular or irregular. You can also ask this to the patient. Ask them about, are there any missed beats or any extra thumps you feel after a gap. Now, this would hint towards any ectopics. The rest is like any known pain symptom. You would elaborate with Odipara. That means the onset. Was it sudden? Was it gradual? The duration. How long does it last? The frequency. How frequently are they getting it in a day? And the pattern. Is there any specific timing? So, when you're asking about the duration, keep in mind if it's seconds to minutes or maybe hours. And you need to also establish whether there's been a change, the progression. So, are they getting worse with time, better, or are they the same? So, If they mention that they're getting worse, you need to clarify if they're getting longer in duration, or are you getting more frequent episodes. This would also help. Ask about any symptoms such as if they're getting it on exertion, any worsening association such as exertion, exercise, or if they're occurring at rest. Next thing would be to ask about any triggers and the timing. So, like I said, exercising. You can also ask about meals if they occur after meals, or if there's any stress that's triggering these symptoms. Ask about caffeine and alcohol specifically. You can ask about smoking at this stage, or you can leave it at the end when you routinely ask about all the personal history. So you can also ask if they've tried anything to stop it, maybe taken some medications, or some patients try the Valsalva maneuver. Maybe they hold their breath or they swallow. So ask them if it relieves their symptoms. Ask about associated symptoms. Since it's a cardiac cause, ask about all the CVS checklist questions first. Is there any chest pain, any breathlessness? If there is, ask about does it occur while you're walking? How far along can you walk before getting breathless? Any dizziness? These are pre-syncope signs. Any dizziness or sweating, giddiness? Ask about loss of consciousness, feeling sick, throwing up, any ankle swelling. For orthopnea and PND, you can ask if they get breathless while they lie down, or if they have to wake up at night feeling breathless or gasping for air. The red flags in this case would be the type B symptoms. So, any raised body temperatures, which notice any change in your weight. You can also ask about any night sweats, or lumps or bumps on their body. Next, ask about specific differentials. You're ruling out thyroid by asking about any abnormal shaking in your hands, any difficulty adjusting to extremes of temperatures, any swelling on your neck. For pheochromocytoma, you'd have to ask about do you get any headaches or maybe a raised blood pressure. You need to rule out anxiety as well. So if ask if they get this symptom while they're in a stressful situation, and if they have been sleeping well. For the drug history, ask about if they're diagnosed with any health condition, if they have been hospitalized before, and ask them to show their medication list if they're on any. And while you're looking at the medication list, ask about any recent change in the dose or discontinuation of any medication or any herbal medication. So, asking about any medical conditions, you're looking for any heart disease, any valve disorders, and maybe thyroid, anemia, or diabetes. For medications, if the patient is asthmatic, they might be on inhalers such as salbutamol or beta agonists. The patient might mention, I'm using a blue inhaler, so blue inhaler would mean salbutamol. Um, Ask about any recent use of antibiotics, maybe macrolides could potentially trigger their symptoms. And asking about any discontinuation of medication would be seen in a withdrawal of beta blockers. You could ask about the recreational drug use here, or save it while you're asking about the personal history along with smoking. So, apologize to the patient, say, so I'm very sorry to ask you these personal questions, but do you take any illicit drugs or party drugs? So, you want to know about cocaine and amphetamine. Ask about the coffee, tea, and energy drink intake. Family history, like I said, is important in conditions such as long QT, Brugada, and hypertrophic obstructive cardiomyopathy. So, ask about has anyone, sorry to ask this, but is there any history of sudden death in your family, or does anyone in your family have a heart condition? After you're done with initial exploration of symptoms, you can then start your review of systems. So, if you haven't asked about thyroid already, you can ask about the sweating, abnormal shakiness of hands, swelling in the neck, weight changes, or maybe dryness of eyes or changes in the appearance of their eyes. For anemia, you can ask about feeling tired more than usual. Has anyone said that you look pale, paler than before? Or if they're diabetic, you can rule out hypoglycemia. If they have been feeling hungry, sweating, feeling dizzy, and if they've checked their blood sugar levels during those episodes. Ask about their occupation and the impact. You need to establish whether they're involved in any kind of public transport, if they're maybe a pilot or a bus driver. So it's important to ask about these. You can also ask about if after you asked about their occupation, you can ask about their any stress that you're experiencing at the workplace if you have time. Now, these are the differentials that you're ruling out with all the questions that we've discussed. So, if the symptoms are brief, sudden in onset, think about SVT, Wolff Parkinson White syndrome, atrial fibrillation, atrial flutter. The difference would be in their regularity. So, if they're regular, think about AVNRT and Wolff Parkinson White syndrome. And if it's irregular, think about atrial fibrillation and flutter. Now, atrial fibrillation, it doesn't end there. You need to establish the underlying cause too. So it can be triggered by a thyroid dysfunction or an underlying cardiac condition. So explore those and make sure to ask about presyncope and exertional intolerance along with these when you're thinking about atrial fibrillation or flutter. Next thing, like we discussed, any missed beats or forceful thumps or forceful sensations after a gap, we're thinking of ectopics, so PVCs or PACs. They're usually benign and they can be triggered by caffeine intake or maybe stress. Ventricular tachycardia would have some serious associations with chest pain or syncope, and maybe an underlying cardiomyopathy or ischemic heart disease. Hyperthyroidism would be easy to rule out with the typical thyroid questions: heat intolerance, goiter, weight loss, and tremors. Anemia, hypoglycemia, and electrolyte imbalance. We've discussed about this as well. Anemia would be ruled out by pallor, dizziness. For hypoglycemia, if they're feeling hungry, sweaty, dizziness, and if they check their blood sugar during those episodes. For electrolyte imbalances, you can talk about dizziness, feeling tired, muscle weakness, or maybe a recent episode of diarrhea or vomiting. And panicking anxiety, although would not present as a main diagnosis, but it's important to show the examiner that you're ruling it out. So ask about any stressful situations or panic. So this is about it. It's actually really easy to approach in the exam, but if you miss a couple of questions, it can be a disaster, because let's say you forget about the family history. It's really important. You can mess the diagnosis. If you do not explore the duration, so duration would matter a lot. If it's lasting from seconds to minutes, if it's longer than that, so it's really important. Also, do not be trapped if, let's suppose, you find the diagnosis, it's a hyperthyroidism, or you figure it out, it's atrial fibrillation, but you fail to explore the underlying diagnosis. And if you fail to explore and rule out other differentials, you might lose marks, because in the clinical communication skill, they want a structured history. So just rushing to get a diagnosis is it not the key. You need to be very thorough with it, with the ruling out the other differentials. So this is about it. Practice this very frequently, because this is often missed by candidates. It is common in the exam, so usually aortic stenosis comes up very frequently in the long clinical consultations. It's an important case, and should be really well practiced. So, if you're appearing in the exam in the next couple of months, you can take the online mock exam. It's based on the real exam format. There will be two LCCs, two communications, and four short stations. After it's done, a feedback will be mailed to you according to the RCP criteria. And I'm also offering a one-on-one coaching session on LCC and communication. So it's of 10 days. In an hour, we'll cover one communication and one LCC. And after the session, we'll discuss about all the mistakes, and written feedback will also be given back to you. And if you just want a crash course, a quick revision for communication, there's a 3 day session. All the important high yield cases will be discussed. So if you're interested, you can send me a DM, follow Paces Guide on Instagram, and you can send a DM there, or you can leave a comment.